And then in the last part, we will talk about which muscle is responsible for what movement. So let us start with the TMJ first. Let me use this picture to make you understand the articular surface of the temporomandibular joint. Well, TMJ, it is, first of all, it is what type of joint? It's a condylar joint. It is a condylar joint, and if you see the proximal or the upper articular surface is by this mandibular fossa. There is a mandibular fossa which is present in the temporal bone, in the squamous part of temporal bone. Inferiorly, obviously, head of mandible is the one which will articulate in it. And the one special feature of this joint, which I can already see in the picture, is that there is a fibrocartilage present inside the joint, which is we call as an articular disc. But as I said, before we talk about the articular disc, now articular surfaces, we said upper articular surface is the mandibular fossa, and you see this mandibular fossa. If I continue with it and go forward, I hope you can see that a little projection there. This projection is called as an articular tubercle. That's a zygomatic arch. In the lower border of the zygomatic arch, you will see a small elevation. This is called as an articular tubercle, and this articular tubercle is also participating in the articular surface of articular structures of the TMJ. And basically, this is the only support, it is the only bony support we have anteriorly for the head of the mandible, which also tells me that why anterior dislocation of TMJ is more common. I mean, posteriorly I have a bone, medially I have bone, superiorly I have bone, but anteriorly I just have a small tubercle called as an articular tubercle, telling you that why anterior dislocation is more common. What else? Posteriorly, this is an external auditory canal. So this here is a tympanic plate. That's again a part of temporal bone. That's a tympanic plate here. But the point to be noted is that tympanic plate is separated from the capsule of the TMJ by some gap. Can you see that space over there? And this space in between is filled with this adipose tissue. You cannot afford to have the capsule attached directly to the tympanic plate, because if that happens, that head of the mandible will be in close contact to this tympanic plate. So even a slightest of retraction injury can lead to the fracture of tympanic plate. Now that is a complication if somebody gets punched on the chin and there is a posterior dislocation of the TMJ, the head of the mandible, the ligaments will break and the head of the mandible will bang against this tympanic plate and can cause the fracture of the tympanic plate. But yeah, we are provided with a support or cushion in between, and that's an adipose tissue which you see between the capsule, posterior part of the capsule of TMJ and the tympanic plate. Inferiorly, it's all about the head of the mandible. Now, coming to this articular disc, what is so special about this articular disc is articular disc fibrocartilage. Now, this kind of fibrocartilage is present in many joints. Sternoclavicular joint is having a fibrocartilage. The best example is menisci. Menisci is an example of fibrocartilage. But, menisci are resting on the tibia. So, the only surface available for the menisci for the articulation is the superior surface. Not in this case. This fibrocartilage, this articular disc, first of all, it is an extension of tendon of lateral pterygoid. Now, that's a lateral pterygoid muscle which is coming backward and is inserted to the neck of mandible. There is a fossa here called as a pterygoid fovea, and also to the anterior part of capsule of TMJ. And the same tendons, the degenerated tendon of this lateral pterygoid muscle, are forming this disc called as an articular disc. And the thing about this articular disc is neither attached to the head of mandible nor it is attached to the mandibular fossa. Therefore, it is divided the TMJ, the temporomandibular joint cavity, in two parts. So now we have a superior joint cavity and inferior joint cavity, which is an advantage because now you can use both the surface of this articular disc for the articulation. Both the surfaces can be used for the articulation, and that's why the frictional forces are not working only on one surface. Unlike menisci, where only superior surface has to undergo all the friction. Now, just look at me. Let's say if this is the head of mandible here and this is articular disc. So if somebody is doing protraction and retraction or any sideways movement, like protraction, retraction, the head of the mandible will go front, will go back. Or if you do the sideways movement or excursion movements like this, that ways again head of the mandible will come sideways like this. In that case, what happens is the movement takes place in the upper joint cavity. What does it mean? The articular disc will move with the head of mandible. Now, this is articular disc, this is head of mandible. If somebody is doing protraction, retraction or sideways movement and these two structures are moving together, so there is no friction in the lower part here. All the friction is subjected in this region because this is where the movement is taking place. So, I will say the sliding, gliding movement, protraction, retraction movement, all these movements, they take place mainly in the upper joint cavity. Lower joint cavity, it also allows some sort of sliding, gliding, But this is a main cavity for the rotatory movements. Rotatory movements means opening and closing of the mouth, where the head of the mandible has to rotate inside here like this. So sliding and gliding there, rotatory movement here. Although sliding and gliding also does takes place in the lower joint cavity to an extent, but that's a main cavity for the rotatory movement. So by doing this, we basically have distributed the frictional forces in two parts. Let the upper cavity for the slide and glide and the lower cavity mainly for the rotatory. And that is an advantage of having an articular disc in the TMJ. We'll talk about its support also. Let's first write about all this. So in the TMJ, first thing we said the type of joint, the TMJ is the condylar joint. It's a condylar joint of the synovial variety. Now in some books they also call it a bicondylar joint. How come bicondylar makes sense? Because although both the condyles are separate, but they have to move together only. Obviously you cannot move one condyle at a time. So both the condyles have to move together only. So we can call it condylar, or some author even calls it bicondylar synovial joint. Articular structures. Let's draw the articular structures. We said the superior articular structures in the lower part of zygomatic arch, there is a tubercle called as articular tubercle. Then we have this mandibular fossa, and posteriorly this here is the external auditory canal. I can just go on further, like there's a mastoid process behind it. There's no need for that. So this is the articular tubercle. The mandibular fossa. Mandibular fossa, as I said, it is present in the squamous part of temporal bone. This here is the external auditory canal, which is lined in its anterior wall and the floor by the tympanic plate. The lower articular structure is the head of the mandible. So let's say this is the head here, and if I just draw some part of the ramus and the angle, that's the head of the mandible. The capsular attachment. Now look at where the capsular attachment. Capsular attachment is right from this articular tubercle to the neck of the mandible, and then posteriorly you will see extending it from the neck of the mandible to the posterior part of mandibular fossa, and not on the anterior wall of external auditory canal. There is a gap over there. That's what we're talking about. This gap here is the one filled with the adipose tissue. So the green color here is for the capsule here. Anteriorly you see attached to the articular tubercle to the neck of mandible, and from the neck to the posterior part of mandibular fossa. The muscle we said, which is coming back and inserting to the capsule and also to the neck of the mandible, to the anterior surface of the neck of mandible, there's a fossa there, is the lateral pterygoid muscle. That's the lateral pterygoid muscle, and this degenerated tendon of lateral pterygoid is the one forming this articular disc inside. This fibrocartilage inside, that's an articular disc. So let's write a little more about this articular disc. So as we said, what this articular disc is, it is structurally it's a fibrocartilage. Structurally, it is a fibrocartilage, and this articular disc, it divides temporomandibular joint cavity in two parts. So we have this upper joint cavity, we got the upper joint cavity, and as we already discussed, upper joint cavity is for what movement? It is mainly for the sliding and gliding. Lower joint cavity, again it allows some sort of sliding and gliding there, but it is mainly for rotatory movements. So that's about the articular disc, the fibrocartilage dividing the joint cavity in two parts, upper and lower. upper cavity for the sliding and gliding movement, lower cavity for rotating movements made. Let's talk about the supports of the temporomandibular joint. Like for any joint, you talk about the main support is its capsule. So for the TMJ also, the major support is by the capsule of TMJ, and then it is reinforced by some ligaments also. So let's look into the supports of temporomandibular joint. Well, we can divide the supports into two parts. We got a true support. We have some true support and some are called as the false support. True and the false support. For any joint, the main true support, as I said, is its fibrous capsule. So the true support for the TMJ also is its capsule. And see, the property of capsule can be remembered if you write this LL by TT. This will help remember that what is the property of the capsule. LLTT will remind you. LL means lower, this loose and laxative in the upper part. I've written it above. So loose and laxative in the upper part. TT I've written it below. It's tense and thick in the lower part. Capsule in the upper part needs to allow the movements like sliding, gliding movements. The head of the mandible need to go forward, backward, and sideways. So upper part of the capsule is loose and laxative. So this LL here reminds you of the loose and laxative, and lower part is tense and thick. The capsule of the TMJ is reinforced by a ligament present on the outside, which is considered as a thickening of the same capsule only, and we call it the lateral ligament. Either you call it lateral ligament or we can call it the lateral temporomandibular ligament. Same thing. Some books simply call it lateral ligament or lateral temporomandibular ligament. Let me show you before I draw this for you. Lateral ligament or lateral temporomandibular ligament. See, that's how that ligament will look like. So this is the capsule here. Let me just highlight the capsule first. The one I highlighted with the yellow here, that's the capsule. And look at this lateral ligament. Lateral ligament, it extends from this articular tubercle again. The fibers are running downward and backward. And then you can see they are winding around the neck of mandible. They're winding around the neck of mandible. So this basically is the direction of the fibers for the lateral ligament. And one should know the direction of the ligament because that tells you which movements they're going to restrict. Whatever direction the ligaments are present in, that's the same movement they're going to restrict. I mean, if the direction of fiber is downward and backward, so that's the movement which they will gonna restrict. So they will restrict the posterior, the retractory movement of the TMJ, and that which makes sense also because when the mandible is protruded, the mandible just needs to come back to its original position. We don't want mandible to go beyond its original position backward because again, what we have posteriorly, we have the tympanic plate here. So imagine if there is a too much of force applied from the anterior aspect of mandible and this ligament is ruptured, then obviously head of the mandible will come back and will hit against the wall, the tympanic plate, and can fracture the tympanic plate also. So that's what the lateral ligament is doing. It is running backward and it is winding around the neck of mandible. So basically it holds the neck of mandible from this part so that it will not go for hyper retraction. So that's lateral temporomandibular ligament. Let's draw it very quickly. This is the articular tubercle and everything that we drew in the previous picture. And we said the ligament is extending from this tubercle. Look at this, it is extending from the articular tubercle, and that's how it is from the lateral side. It is winding around the neck of mandible. So it mainly provides a support on the lateral side and obviously on the posterior side also because it grabs the neck from the posterior side. So the function, what is the function of the ligament? We said it prevents hyper retraction. It prevents hyper retraction. mandible should be allowed to come back to its original position and not go beyond that certain point. So it just prevents the hyper retraction. Now, these are the two true ligaments. The true ligaments or true capsule, when we talk about, they are made up of the fibrous structure. I mean, any true ligament is a condensation of the capsule only. You look at any ligament, whether it's a shoulder joint or a hip joint, the capsule itself is thickened to form those true ligaments around. False ligament of TMJ, and first of all, why those ligaments are called as false ligament? It's not because of their structure, is because they are not in relation to the TMJ directly. You will not see those ligaments reinforcing the capsule, immediately reinforcing the capsule. They are present like far away from the joint, but they're still holding the mandible. That's why they are like support only. The two ligaments forming the false support are, we have stylomandibular ligament. We got the stylomandibular ligament, and we got sphenomandibular ligament. Stylomandibular ligament and sphenomandibular ligament. Once again, let's have a look at the picture and then we'll talk about them. As the name suggests, stylomandibular and spheno. Styloid, one will be coming from the styloid process and one is coming from the spine of sphenoid. That's why sphenomandibular. But none of them is attached to the capsule or close to the capsule, as you can see in this picture here. Look at these two ligaments, guys. This here is coming from the styloid process. You can see the styloid process there above. So it is coming from the styloid process and all the way to the angle of mandible. So this, of course, is the stylomandibular ligament. Whereas the ligament here, which is coming from the spine of sphenoid. See, spine of sphenoid is the most posterior part of the sphenoid bone. That's how, when you look at the base of the skull, it's not easy to identify that where exactly sphenoid bone is ending and occipital bone is starting. So these are some landmarks that one should know. That spine of sphenoid is the most posterior part of the sphenoid bone. So from that spine of sphenoid, the ligament coming, and this is the medial surface of mandible. Obviously, you're not looking at the mandible from the outer aspect, you're seeing it from the medial side. So from the spine of sphenoid, the ligament is running on the inner half here and is attached to a small tongue-like projection, which is guarding a mandibular foramen here of the mandible, and that is called as a lingula. This tongue-like projection here is called as lingula. And that above here is the spine of sphenoid. So the ligament here is called as a sphenomandibular ligament. The most posterior part of the sphenoid bone, the spine of the sphenoid, from there to the lingula, which you see on the medial surface of ramus of mandible, which is partly guarding this mandibular foramen there. That is, the ligament here is sphenomandibular. And I hope you remember these two ligaments were discussed in the cervical fascia also. They are the modification of the investing layer. Rule of 2 for the investing layer. So even two ligaments were there. Stylo and the sphenomandibular ligament both are made up of the deep cervical fascia, investing layer of deep cervical fascia. One important thing which I should tell you here itself, that sphenomandibular ligament, between the sphenomandibular ligament and the capsule, that is a capsule of the TMJ, and the neck over, there's a neck below. So you will see the maxillary artery, the largest branch of external carotid artery, that maxillary artery is passing between the two. So between the neck of mandible is obviously toward the lateral side and sphenomandibular toward the medial side. In between the two, then one major vessel there is the maxillary artery. So these are the two ligaments, the two false ligament. As we said, why the false ligament? Because they are not in relation to the capsule, they are far off. So we said the false support is stylo and the sphenomandibular ligament. If I also roughly draw it for you, that is the mandible here, the head of the mandible, the notch. If this here is the styloid process, there is a ligament from the styloid process to the angle of mandible. And if this is the spine of the sphenoid, there is a ligament extending to this tongue-like projection, that is a lingula. This is sphenomandibular ligament. So this is number 1 in our list, that is stylomandibular. This is number 2, it is sphenomandibular. And as we already said, you will see maxillary artery. The two false ligament of TMJ. The true support was capsule, and the one true ligament was lateral temporomandibular, and the two false ligament is the stylomandibular and sphenomandibular. Before we go to the muscles and the movement part, what is the nerve supply and the blood supply of TMJ, guys? It's pretty simple. See, nerve supply of TMJ, one is the auriculotemporal nerve. We discussed in the mandibular nerve only. A branch of the mandibular nerve called as auriculotemporal nerve supplies the auricle and temple region, the skin of the temple and auricle. It supplies parotid gland and TMJ also. So one nerve is auriculotemporal nerve, and even mesenteric nerve supplies it. Nerve supplying the masseter muscle, mesenteric nerve supplies it. Whereas the arterial supply, the blood supply of TMJ, now think about the two branches of external carotid artery which are in close relation to TMJ. The two terminal branches of external carotid artery. One is maxillary artery and one is superficial temporal artery. One is superficial temporal artery. So there is a nerve supply and the blood supply of the TMJ. Auriculotemporal nerve coming from the posterior division of mandibular nerve. Mesenteric nerve which is coming from anterior division of mandibular nerve. So that's anterior division of mandibular. This is posterior division of mandibular nerve. Both supplies it. Arterial supply, think about the two artery closest to TMJ. The two branches of external carotid artery closest to TMJ are the two terminal branches. Maxillary, superficial temporal, and both gives the blood supply to the temporomandibular joint.
So in this part, we'll talk about the muscles of mastication. Well, to understand the muscles of mastication, we first need to understand that how these muscles are inserted on the mandible, and then based on the direction of the muscle fibers towards the mandible, we can make out what their function is. Because, just keep on mugging up the names of the muscles and then trying to remember that what their function is, it's a bit difficult. But if you have a proper understanding of the direction of the muscle fiber, then you can always think about that how the contraction will bring the insertion point toward the origin and what all it can cause. A muscle doing one function can be doing other function as well. Like a muscle, if there is a muscle, temporalis muscle is for the elevation of mandible. Now, apart from elevation, what else it can do? It can be understood by looking at the direction of the muscle fibers. So first I'll make you draw a picture of a mandible, as just a schematic diagram to see how the muscles are inserted. Then I'll show it on some atlas images, and then finally we'll write about those actions. Well, needless to say, there are four muscles of mastication. We've got a medial pterygoid, lateral pterygoid, temporalis, and the masseter. Temporalis is the largest muscle. If I talk about the size, the temporalis is the largest muscle, and masseter is the strongest muscle of the mastication, the one which is present outside the ramus of mandible. Now, let's say we are looking at the cut section of the mandible. Here's the head of the mandible here, the neck. That is a mandibular notch, coronoid process, and that is the body. And I'm not drawing the mandibular tooth. And let's presume this is the view of the mandible from outside. You're seeing it from the lateral side, from the outer aspect here. So out of the four muscles of mastication, barring medial pterygoid, other three muscle can be seen from this surface also. Like the temporalis muscle. Now, just for the orientation thing, guys, this picture is also obviously having superior, this is inferior, anterior on this side and posterior on this side. So that's anterior and that's posterior. I've just wrote it so that you remember that what is the direction of the fibers. The temporalis muscle will be coming downward like this and inserted to the anterior border of ramus of mandible. Anterior border of ramus of mandible to the coronoid process and also to the medial surface of this coronoid process. So it's to the anterior border. You can see it's extending to the anterior border of ramus of mandible, to the tip of this coronoid process, and also to the medial surface of this coronoid process. And it's important to know that exactly it is extending to the anterior border, because sometimes, let's say, if they show you the section of the mandible rather than showing you the lateral view or something, if they give you a picture or a transverse section of the head and neck region from where you can see the section going through the ramus of mandible. So if you see a muscle attached on its anterior border, okay, or even slightly on the medial surface, but medial surface along with the anterior border. So don't think that muscle is medial pterygoid, that is temporalis muscle. You need to see whether the muscle is close to the anterior border and then on the medial surface in that respective region. So that's how these fibers are coming. It's very important to understand that the direction of the fibers, as I said. So the muscle is temporalis. The muscle is temporalis. So what is the direction? The fibers are coming, and when I say direction, we have to see the muscle directed toward the insertion. Obviously, I will not say the direction towards the origin. I will say the direction toward the insertion, because that is a point of movement. So these fibers are coming, obviously they're coming downward, and they're also coming forward. If you see, they're coming from posterior to anterior slightly. So a big chunk of this muscle is also running forward also. So temporalis muscle, it runs downwards and forwards. Downwards and forwards. The muscle runs downwards and forwards. The neck of mandible. Now, this neck of mandible, there is a small depression on this neck of mandible which is called as a pterygoid fovea. The pterygoid fovea. And this pterygoid fovea is providing insertion to the lateral pterygoid muscle. Lateral pterygoid muscle is not only to this pterygoid fovea, also to the capsule of the TMJ. Now, let us presume this here is the capsule of temporomandibular joint. We've already talked about it. So, the lateral pterygoid muscle is oriented backwards to the capsule and also to that fovea, that is pterygoid fovea here. So, this here is the lateral pterygoid muscle. It originates from the lateral surface of lateral pterygoid plate, and then it is inserted. It is basically going backwards. Obviously, you can see the fibers are going backwards. Lateral pterygoid plate will be somewhere here in this region, and then it is going backwards towards the capsule and to the pterygoid fovea. So the direction of the muscle fiber is mainly backwards. It mainly goes backwards. On the outer surface of ramus of mandible, the muscle that I can see there is the masseter muscle. So what you will see, the masseter muscle is inserted on the outer surface of the ramus of mandible, and look at the direction here. That's how the masseter will be coming. It is coming from the zygomatic bone and zygomatic process. The strongest muscle of mastication, the masseter muscle, and the direction is, of course, it is coming downward. It's mainly coming downwards. But look at the direction, guys. If I just put an arrow here, it's coming downwards and slightly backwards also. It goes slightly downwards and backwards, which we'll appreciate in the picture also. Downwards and backwards. And finally, we got a medial pterygoid muscle. As I said, I cannot depreciate medial pterygoid on this section. Medial pterygoid is on the other side, but masseter fibers and medial pterygoid fibers are more or less running in the same direction only. So even medial pterygoid muscle, which originates from the medial surface of lateral pterygoid plate. Now also remember that lateral pterygoid plate and medial pterygoid plate. Medial pterygoid plate is not giving origin to the muscles of mastication. It is only the lateral pterygoid plate. So if this is the lateral pterygoid plate, the lateral surface is for lateral pterygoid, and the medial surface of the same lateral pterygoid is for medial pterygoid. So it's a medial and lateral surface of lateral pterygoid plate only. And that muscle will also come downwards and backward, but medial to the ramus of the mandible and the angle of mandible. So if I just for the completion's sake, if I just draw these fibers here, I'm putting a dotted line because it's on the medial side. So the muscle is medial pterygoid, and the direction is, again, can say downwards and backwards. Downwards and backwards. We'll understand the significance of the direction of muscle fiber, but I just want you to first memorize these things, that temporalis fibers are coming downwards and forward. So you will see this word forward only with the temporalis muscle. See, these are some unique things here. Forward fibers you will see only for the temporalis. No other muscle is going forward. Then, which other muscle is having something unique about it? Lateral pterygoid. That's the only muscle which is going what? Backwards. Mainly backwards, what I want to say here. Backward. We have a masseter going down backward also. This is also going backward, medial pterygoid. But when you look at their action, the main muscle which is going backward, I should not say only, the main muscle which is going backward is lateral pterygoid. So main muscle going forward is temporalis, and the main muscle going backward is lateral pterygoid here. Downwards, well, which muscle is not going downwards? This is downward, this is downward, this is downward. Lateral pterygoid is not going downward. That means there has to be something different about the action of lateral pterygoid in comparison to these three muscles. Because all these three muscles are going downward, so they must be having something common in their action which will be different from lateral pterygoid. Let's see. Let's look at the picture of for all these muscles and then try to look into those details. Now look at one muscle at a time, guys. This here is the temporalis muscle. You can see it is originating from the temporal fossa. So this big muscle is temporalis, and you look at the direction of the fibers. These fibers are running downwards toward this process, to the coronoid process, and majority of the fibers from the posterior side, they are going forward also. So it's downward and forward, and you can see it is attached to the process. The tendon are extending to the anterior border as well. If I just try to enlarge it for you, I hope you can see that extension of the tendon of insertion on the anterior border of the ramus of mandible, and also to the medial surface. So it's basically tip, medial surface of the process, and then on the anterior border of the ramus of mandible, the temporalis. So think, now if this is the muscle you're looking at, you already know the direction. What could be the action, guys? These muscles which are fiber which are running downward, they obviously will pull the mandible in this direction, and those fibers which are running forward, they will pull the mandible in that direction, because the direction is this, downwards and forward. So obviously when the muscle contracts, they will take the mandible toward the point of origin. This tells you that these fibers, the more anterior fibers of temporalis, are for the elevation of mandible. They will pull the mandible up, or you can say closing of mouth. And posterior fibers will pull the mandible backward, so they will help in the retraction. When you protrude the mandible forward, the retraction will be done by the posterior fiber. So if the question says that what is the action of temporalis muscle, so it has to be what? Elevation of mandible and also the retraction of mandible. Obviously the retraction of the protruded mandible. Well, you will not be able to retract the mandible from its original position. So it's the retraction of the protruded mandible. Elevation and retraction. We'll write about it, just keep it in mind first. Look at this muscle. The next muscle I'm showing you here is the masseter muscle. Now this here is the masseter muscle. What's the direction? Don't get carried away with this white color here. It's a tendon of origin and not the insertion. So direction is still downwards and backwards. You can see downwards and and backward is the direction inserted onto the lateral surface of the angle of mandible and ramus. So obviously when this muscle contracts, it will pull the mandible in this direction. Well, what this direction tells you, that obviously it is elevation, it is upwards, and it is slightly forward also. The arrow is going slightly forward. So this will help, definitely will help in the elevation of mandible, just like temporalis. But because orientation of fibers are in this, slightly toward the forward, in the forward direction, so it also helps in the protraction. Not a major muscle for protraction, but it helps in the protraction also. And that's because of the direction. So if this muscle fiber contracts, the mandible will go up and slightly forward also. That is elevation and protraction. Here are the remaining two muscles. Well, this is the lateral pterygoid and this is medial pterygoid. Now, once again, medial pterygoid, we just have to cut the ramus of mandible to see the medial pterygoid, because masseter was on the outside. Once remove the masseter muscle, cut the ramus of mandible, and then I can see the medial pterygoid muscle, but the direction is the same. Isn't it just like the masseter muscle only? So even medial pterygoid action will be what? It will elevate the mandible and it will slightly protrude the mandible also. Helps in the protraction. And then comes the most interesting muscle, probably the muscle which is most commonly asked in the exam also, because in the previous 3-4 years, if you look at the questions on the previous 3-4 years, they keep on asking question on the lateral pterygoid muscle most commonly. Only thing is they will keep on changing the view, sometime from the lateral view, sometime inferior view, maybe a sectional view, and they will ask you the action of this muscle. One thing, this is the only muscle which is not going upward. You can see the direction is like this. The direction is it's coming toward the capsule and toward the neck of mandible. So first of all, this muscle helps in the opening of the mouth and not the closing of the mouth. So this helps in the depression. Especially these fibers, the lower, it is having two bellies here, up superior belly and the inferior belly, or you can say the upper head and lower head. And this lower head actually will help in the, first of all, it will help in what? Opening of the mouth, number one. Number two, this is one main muscle going backward. Medial pterygoid was also going backward. Masseter was also going backward slightly, but that's the main muscle going backward. So the contraction of this muscle will pull the mandible forward. That means in this direction, and that's why it is a main muscle for protraction. If you have to choose one best answer for the muscle for protraction, it has to be the lateral pterygoid, which also helps in the opening of the mouth. Another interesting fact about the medial and lateral pterygoid is that the alternate action of lateral and medial pterygoid also helps in the excursion movement, the side to side. This is also the movement possible at the mandible. So this side to side movement is because of the alternate action of lateral pterygoid and medial pterygoid, and that is the one which will protrude the which will take the mandible to the other side. That is the sideways movement. So knowing about the direction of muscle fiber, let's quickly write about them, the movements. So let's start first with the elevation. And as I said, when we say elevation of mandible, we are talking about the closing of mouth. Elevation of mandible, that is the closing of mouth. And this elevation of mandible or closing of mouth is done by the muscle which are going downward. Which muscles were those? That was, we had temporalis. We got temporalis in the list. We have masseter and also the medial pterygoid. You know the drill. We just have to see the muscle running downwards. The second movement, that is the depression. Depression of mandible, or you can say opening. Opening of mouth. Depression of mandible or opening of mouth is done by the muscle which we have not written here till now, that is the lateral pterygoid muscle. Lateral pterygoid. Now see, there's a thing about the depression, guys. Lateral pterygoid, yes, if you have to choose an answer between the muscle of mastication, which one is helping in the depression, it obviously is lateral pterygoid. But first of all, there is no muscle needed as such for the depression. I mean, if you just relax all the muscle of mastication, then your mouth will open automatically, and that is due to gravity only. So I would say gravity is the prime mover here. You must have seen the people, like if they fall asleep sitting on the chair, sometimes their mouth will automatically open. The gravity will just pull the mandible down. So as such, for the normal opening of the mouth, there is no muscle needed. Just the relaxation of all the muscles of mastication can lead to it. Lateral pterygoid is one muscle of mastication which helps in this opening more effectively. But the thing is, if this opening of mouth or depression of mandible is done against resistance, let's say if I apply resistance here and then I try to open my mouth, then lateral pterygoid alone is not able to do that. Then we need something beyond muscles of mastication. We need muscles which are attached to the mandible from the inferior surface of the mandible or the inferior border of the mandible, like anterior belly of digastric. We have a mylohyoid line, so we have mylohyoid muscle present here. Then we have a muscle called as geniohyoid. So all these muscles which are attached to the lower part of mandible, which will pull the mandible downward toward the mandible or below, that will also help in the depression. So I would say that if this depression is against resistance, if it is against resistance, then we also need mylohyoid. We need lateral pterygoid then also, but we need mylohyoid. We'll be needing anterior belly of digastric and geniohyoid muscle as well. So it's an additional group of muscle which are not the muscles of mastication, but they will help in the opening of mouth when some sort of resistance is applied to the mandible. Elevation, depression done. Now coming to the protraction and retraction. Now first is protraction. Protraction can be done by the muscle which is going backward, that will pull the mandible forward. The main muscle going backward was the lateral pterygoid. The lateral pterygoid is the major muscle if you have to choose one single muscle. And this lateral pterygoid is basically assisted by which two other muscles which are going backward? It was masseter as well as medial pterygoid. Masseter and medial pterygoid are also going slightly backward when they're running downward. So they will also assist slightly in the protraction, but yes, the main muscle for protraction is lateral pterygoid. Retraction. What about retraction? Retraction is done by those posterior fiber of temporalis muscle. Well, that's the only muscle which is going forward. So clearly that is a muscle needed for the retraction, to pull the mandible back. Elevation, depression, protraction, retraction, and finally coming to the sideways movement. Sideways movement, also can call it the side to side movement or the excursion movement of the mandible. And this excursion movement or the side to side movement is done by the alternate action of lateral and medial pterygoid. Alternate action of lateral and medial pterygoid is for the side to side movement of the mandible. So this is about the muscles of mastication, the direction of the muscle fibers, and then what exactly they will cause. And I would once again repeat this thing, that the muscles of mastication is very, very important. TMJ and the muscles which are responsible for the movement at the temporomandibular joint, this question has been asked over and over again. And the thing is that, as I said, in the image based question, they will give you the different view in the different sections. So the first challenge is to identify the muscle. So rather than like trying to like mug up those muscles on those different sections, the first thing is if you understand where the muscle is inserted. So that will enhance your understanding. If you know that muscle is obviously on the medial side of ramus of mandible, so it doesn't matter whatever section they will give it to you. If you see that, if you can recognize the section of the mandible, then obviously you expect to see the medial pterygoid on the medial side, the masseter on the lateral side, and so on, right? So that's about the TMJ. We already talked about the dislocation of TMJ. The most common dislocation of temporomandibular joint is the anterior dislocation. The only thing which is supporting the head of the mandible in front is the articular tubercle. It's a very small tubercle only. So the excessive opening of the mouth can also lead to this anterior dislocation. The head of the mandible can come out because it is just supported by a very small tubercle, the articular tubercle.